Chers maîtres, chers confrères, honorable passe-président, honorable invité, c'est un grand plaisir d'être avec vous en ce jour pour le 37e congrès de notre société, la Société tunisienne de chirurgie orthopédique et traumatologique, la SOTCOT. La SOTCOT poursuit sa tradition de qualité et d'innovation dans la lignée de ses pionniers et de nos maîtres. En organisant le 37e congrès à Tunis sous la présidence de mon ami Dr Sofiane Khalel et en partenariat avec l'AO-Trauma, l'ISACOS, la CICOT, le Collège national d'orthopédie, la CITCOT Junior et l'Oxford Group of Sarcoma. Le programme scientifique est généreux et diversifié, enrichi par la présence physique et virtuelle de nombreux invités, ou plutôt amis, venus des 4 coins du monde. Nous les remercions pour avoir répondu à notre invitation et leur souhaitons la bienvenue et le bon séjour en Tunisie, terre d'accueil, marhaba bik mneskour. De nombreux orateurs tunisiens de qualité que nous remercions, comme nous remercions les différents groupes de travail de la SOTCOT pour avoir travaillé sans relâche pour nous présenter les résultats de leurs recherches. Le mandat de bureau que j'ai eu l'honneur de présider touche à sa fin. Présider la SOTCOT n'est une mission commune, mais un défi pour maintenir le niveau de notre spécialité et surtout la faire évoluer. Ce mandat exceptionnel de 3 ans a été assez particulier en raison de la situation sanitaire internationale, qui nous a obligés à de profonds bouleversements. Mais nous avons su nous adapter en travaillant davantage en distanciel, en avançant sur plusieurs projets avec un bureau dynamique que je voulais saluer. Comme je voudrais remercier tous ceux qui ont, par ces conditions difficiles, organisé des webinaires et des congrès au nom de la SOTCOT. Donc, lors de notre mandat, après la réussite des journées de décembre 2019 à 12h, présidée par mon ami Dr Aissam Aloui, et au cours de laquelle il a eu la création de la société SOTCOT Junior, qui est une société dynamique de jeunes résidents en orthopédie qui vont assurer la relève. Notre mandat a été perturbé par la pandémie Covid-19, ce qui nous a obligés d'annuler le congrès de l'AOLEF 2020 et le congrès de la SAFO prévu en 2021. Pour autant, notre activité scientifique a été maintenue en assurant les journées d'hiver en décembre 2020 organisées par l'équipe de Mahdir, le 36e congrès national de la SOTCOT organisé par Dr Mourad Jenzri en distanciel. De plus, le bureau a organisé plusieurs rencontres sous forme de cas cliniques ainsi de symposiums dirigés par les groupes d'études de la SOTCOT, donc le groupe de chirurgie hanche-genou, chirurgie pédiatrique et le groupe de chirurgie de pied. Après la pandémie, on a pu organiser les journées à Sousse sous la présidence du Dr Jdidi et au cours de cette manifestation, il y a eu la réparation de la revue Tunisie orthopédique dont j'invite tous les orthopédistes à soumettre leurs travaux. J'insiste sur la collaboration avec le Collège national d'orthopédie qui ne cesse de se planifier avec la participation au cours de collège, l'organisation des symposiums et la présentation des manifestations avec d'autres sociétés et d'autres collèges comme on a fait derrière moi la Société tunisienne de pathologie infectieuse ainsi que la création du prix de la meilleure thèse en orthopédie. Le bureau sortant félicite donc de nouveau le nouveau membre de la SOTCOT, les jeunes orthopédistes réussis, ainsi que les membres promis dans leur carrière, à savoir l'assistant hospitalier universitaire, les maîtres de conférences agrégés et les professeurs. Dans cette occasion, je ne peux pas le passer sans rendre hommage aux orthopédistes que nous ont quittés pendant cette période. Et je rends hommage à notre maître, le professeur Meher Beghachem, ancien président de la SOTCOT, qui nous a quittés il y a quelques mois. Le 37e congrès de la SOTCOT, confié à un comité présidé, comme j'ai dit, par Dr Khalel Sofiane, et le rendez-vous de l'excellence scientifique et de la diversité des expériences, s'appuyait sur d'éminents orateurs tunisiens parmi les membres de la SOTCOT et de représentants des différentes sociétés étrangères et particulières que je salue particulièrement, tout en souhaitant la bienvenue en Tunisie. Je souhaite à tous un excellent congrès. Vive la SOTCOT, vive la Tunisie, et je passe la parole à mon ami Sofiane Khalel.
Thank you very much. Then we listen to 2 other languages in English and in Arabic. Distinguished delegate and invitees, ladies and gentlemen, I am indeed very happy to be with you and honored to be the president of the 37th SOTCOT meeting on behalf of our National Society and a very dedicated organizing committee that I may ask you to applaud. I sincerely welcome all of you today in Tunis and wish you all a pleasant stay. I am happy to declare open the 37th meeting of the Tunisian Society of Orthopedic Surgery and Trauma, the first English-spoken and digitalized orthopedic medical meeting in Tunisia. بسم الله الرحمن الرحيم. أيها السادة الأكارم، حضرة الحضور، بداية يسرني أن أرحب بجميع الحاضرين الذين شاركوننا هذا اليوم المهم في تاريخ منظمتنا العريقة الجمعية التونسية لجراحة العظام والمفاصل. هذه المؤسسة التي تسعى منذ نشأتها المساهمة المباشرة والفعالة التي تنمي للنهوض بمستوى تكوين جراحي العظام وطنياً وعالمياً للاستجابة إلى إسداء أرقى الخدمات للمواطن التونسي. أيها السيدات والسادة، إيماناً منا بضرورة الارتقاء بمستوى المعرفي والعلمي وبوجود كفاءات هائلة لدى شبابنا وإرادة قوية لرفع التحديات التي تفرضها علينا التحولات التي يشهدها العالم، يقام المؤتمر هذه السنة باللغة الإنجليزية ليكون نقطة تحول في نوعية إقامة التظاهرات العلمية والطبية، خاصة ليكون أول مؤتمر طبي تونسي يقام باللغة الإنجليزية كاملة في تونس مع تسجيل مرقماً حسب التطبيقات المعتمدة. يشرفني شخصياً باسمي الخاص وباسم الهيئة المنظمة للمؤتمر التي تفانت لمدة 6 أشهر متتالية دون توان لتقديم هذا المستوى الرائع لافتتاح الدورة 37 للجمعية التونسية لجراحة العظام والمفاصل والكسور. يشارك في هذا المؤتمر مجموعة من الجراحين المعترف بهم عالمياً من دول صديقة وشقيقة، كما يسجل المؤتمر العديد من المشاركين من الدول الشقيقة والصديقة من 4 قارات في العالم. نشكر كل الجهات التي ساعدت على إنجاح هذه التظاهرة وكل المشاركين، وشكرا لكم للحضور، وإن شاء الله مؤتمر موفق.
كنت موجود في مؤتمر في الدنمارك، لقيت بالعرض الدكاترة بيعرضوا على ازاي الكسر مثلا في الفخذ في مسامير كتير جدا وشرايح كتيرة جدا، فطبعا دي حاجة جديدة بالنسبة لمصر.
الجمعية دي جمعية انشئت سنة 58 في سويسرا بهدف تطوير طرق علاج الكسور وعلاج أمراض جراحة العظام بوجه عام.
على مستوى الوطن العربي اتخذنا قرار الزملاء جميعا في الوطن العربي، الأردن ومصر والسعودية والخليج، إنه يكون لنا كياننا واتصالنا الخاص مع ال AO International.
And in 2006, we have established, with the help of 9 countries in the region, the first AO trauma board in the region.
The most important aim for us was to deepen the level of networking with other regions in order to strengthen ties and to improve patient care.
في بوتنشال عالي جدا فينا اللي احنا نزيد في النمو، وبنخش فاكولتي كتير ونخش بلاد كتير بتنضم للاي او كل سنه. So we are still growing.
AO has been a significant part of my professional and personal life for more than 20 years. It allowed me to interact with people across the globe, where you meet different people and learn from them, as well as involved in the teaching process.
By research, we mean the future. So now AO is focusing on the future and is giving a chance for everyone all over the world to communicate and to share in the future of the fracture management through the AO Trauma Research Committee.
And for that, they started the Research Institute for the basic science and the CID for the clinical research. Also, they started the AO Peer program, which is an AO program for education and excellence in research.
كان أول كورس في دبي، عندي خبرة كويسة جدا جدا جدا، ما بخليش الدكتور يطلب مني أي حاجة في العملية بمجرد ما بعرف البلان بتاعته إيه.
AO Trauma is embarking on 2 new projects, which we think are going to enhance the way our surgeons train. One of them is the competency assessment training program. The other program has to do with blended learning, which goes hand in hand with the first project.
We are lucky that we are living in the AO trauma time. Thank you.
Thank you all for attending this part of the Congress. And thank you for the Tunisian Orthopedic Society to invite us to participate in their 37th Congress. In the AO, we want to serve you all, and we want to get you all with us. So the AO in the Middle East, as you have seen in this video, has been there for quite a long time now. And it affected the life of so many of us. And we are so keen that we get more and more, especially more from Tunisia here, to join and become members of the AO. As you have seen, the AO in the Middle East, we have presented the Middle East internationally, and Dr. Wael Taha, for example, who was the Education Commission chair of all the AO, now became the chair-elect for the AO Trauma International Board, which is the highest or the most prestigious position in the AO. So the Middle East has participated actively in this, and we are hoping that we get our new generation involved and with us in the AO. We're going to have the course next week here in Tunisia, and hopefully this will be one of the courses that are going to be for the coming years in Tunisia. Again, we want to welcome you all here, and as the chair of the Middle East North Africa AO Trauma, I'm inviting everybody here to join, and to be a member and benefit from the AO in the region. Thank you.
نظرا لاستضافة المجلس العربي للاختصاصات الصحية مع الدكتور رمزي بوزيدي في تونس، محمد راشد مشي يقدم لنا في دقيقتين البرنامج التعاون هذايا ما بين مجلس الاختصاصات الصحية في المجلس العربي وتونس.
بسم الله الرحمن الرحيم. باسم الأمين التنفيذي للمجلس العربي للاختصاصات الصحية وبالأخص المجلس العلمي لجراحة العظام، وبناء على دعوة من الزملاء في الجمعية التونسية لجراحة العظام والمفاصل، يشرفنا حضور ثلة من الزملاء في المجلس العربي للاختصاصات الصحية لحضور هذا الحفل ولحضور مناشط الجمعية التونسية لجراحة العظام. في سبيل تطوير جراحة العظام في الوطن العربي فتحنا قناة جديدة للتواصل مع الزملاء في المستشفيات التونسية، وبالأخص عملية الاعتراف بالنظام التدريبي الذي سيتلو عليه الأستاذ الدكتور رمزي البوزيدي مع زملائه كيفية مناشط المجلس العربي، والبداية ستكون بمستشفى المرسى وبعض المستشفيات الأخرى، وبالتالي نكون قد فتحنا صفحة جديدة مع المغرب العربي بصفة عامة وبالذات في الجمهورية التونسية. شاكرا لكم الاستضافة لي ولزملائي، وبارك الله فيكم دائما، والسلام عليكم ورحمة الله.
Then we continue a scientific program with the AO Symposium about intracapsular femoral neck fractures.
Thank you, Mr. Chairman. Thank you, everybody. Where's my lecture? Okay. So the first lecture in this symposium will be when to use cannulate screws versus sliding hip screws in intracapsular neck-femur fractures. Why it doesn't advance? Okay. So this is an 18-year-old male skier, high-speed injury into a tree. This is an isolated injury. How are you going to treat this, Arthur? Yeah.
So, again, considerations here is the injury itself, and in 18-year-old skier, I would probably like to opt for an open reduction in term fixation.
So open reduction in term fixation. You are going straight away for the open reduction.
Sorry, close reduction in term fixation.
Well, what fixation technique are you going to use? Screws. So in this lecture, we are going to describe the importance of reduction in femoral neck fractures fixation, discuss the options of femoral neck fracture fixation, and compare the advantages and disadvantages of each of them. As an overview for femoral neck fractures, they are common proximal femur fractures. As you know, in elderly, they are usually low energy. In youngsters, they are usually high energy. And they are classified either by location into subcapital, transcervical, and basicervical, or according to the displacement by Garden into 1, 2, 3, and 4, or according to the orientation by Powell. And this classification by Powell will come into play a lot for the choice of the implant, especially that there is a strong correlation between the non-union and AVN risk and the Powell classification of the fracture. Neck-femur fractures, as you know, intracapsular fractures, they pose special biological and mechanical considerations. Being intracapsular, this means that the callus formation is limited. Blood supply runs from the neck to the head, which means the broken neck will compromise the blood supply of the head, in addition to other mechanical considerations like the strength of our fixation, the void which is present inside the neck and the head, osteoporosis, and many other considerations. Treatment options in general for femoral neck fractures, as you know, in elderly, we go for arthroplasty. In youngsters, we go for fixation. However, reduction is the most important factor and is of paramount importance. As for the fixation, should be strong enough to bear the stresses of the physiological load and, of course, to preserve the blood supply of the head. Otherwise, it will defy the whole purpose of your surgery, reduction and fixation. For the fixation, we have many options: cannulated screws, we have sliding hip screw with a anti-rotation screw, and some newer concepts we are going to talk about. So the fixation options for femoral neck fractures, which is the topic of this lecture, unfortunately, there is no consensus about the ideal fixation device. As you know, so many publications with no conclusive results. However, there are some factors we need to consider. For example, in cannulated screws, there are many configurations and many orientations. There are controversies to use 2, 3, or 4 screws, fully threaded versus partially threaded. It has been found that the inverted triangle configuration shows mechanical and clinical superiority. The inferior screw here, it's too big. It resists compression in the upright position. It should be below the lesser trochanter, as close as possible to the inferior cortex. The superior posterior screw should be as close as possible to the posterior neck cortex, and it resists tension in the upright and compression in setting. And the superior anterior screw resists tension in the upright and sitting position. Advantages of cannulated screws: as you know, it's biologic, minimally invasive, rotationally stable. It has been reported to have lower risk of AVN, and it is of low cost and fast procedure, less blood loss, because it is a minimally invasive technique. However, there are many disadvantages for the cannulated screws, being not an angular stable device, which means they are bad in resisting vertical shear. Therefore, they are not suitable for the vertically oriented fractures, as you see there. They might collapse very easily. There's also less control over the compression at the fracture site in the cannulated screws, and there's a higher risk of cutout, especially in osteoporosis. Sliding hip screws in general, you should aim for center position in the head, in the AP and lateral projections. Go very deep where the best bone is, in the best purchase in the subchondral bone. Aim for a tip apex distance of less than 25 millimeters. As for the side plate, 2 holes are usually sufficient, but you need an anti-rotation screw because it is rotationally unstable alone. The advantages of sliding hip screw in treating femoral neck fractures. In contrary to the cannulate screws, these are fixed angle devices, therefore they are mechanically more stable in vertically oriented fractures, and it also provides compression at the fracture site and better to be used in osteoporotic problems. Disadvantages, however, it requires additional screw for anti-rotation. As you know, it is not stable alone in rotation, and it is reported to have a higher risk of AVN according to the FAITH trial, which reported 9% AVN. More blood loss because it is not as minimally invasive as the cannulate screws and needs more time. So if you are wondering which to use, cannulate screws versus sliding hip screws, cannulate screws report better results when they are used for horizontal fractures like Powell 1 and 2, and better bone quality like this fracture here. See, it is rotationally stable, it can control compression. Sliding hip screws on the other side should be used for a vertically oriented fracture, Powell 3 and osteoporotic bone. New technology, new options are available now, combining the advantages of both the cannulate screws and the sliding hip screws. These are the lateral plate with locking compression screws like the femoral neck system. They are angular stable, resist vertical shear, control rotation, control compression, and eventually they are minimally invasive. So this is our case, the first case. They did a limited open reduction, and this is what they got. So what do you think, Athir, now? Reduction. Reduction is key. What else? Sorry? The reduction, there's still a gap. So who's happy with this? So who's not happy with this? Good. So you are all correct because this is 5 days later. So what are you going to do now, Hashim?
We should remove all these screws. We should, before the CT scan, to see what is the cause of failure to have compression.
What do you think the cause of this failure?
Maybe some rotation on the neck, also incarcerated bone fragments.
There's a CT scan.
Yes. So I think the bone there at the calcar area had stopped, or as a door stop for the reduction and for the compression to be achieved. There is multiple also tracks for the screws, multiple trials maybe, or after the failure of these screw, they collapsed in this way. So I think the CT scan is beneficial. Then also we should assess the screws if some of them had been broken in the tract. Then
so what are your options now?
To remove all the metal.
Remove all the metal.
I will do open reduction internal fixation through...
Open now.
Yes.
Open.
Open. And
anybody would leave it like this?
Mm-hmm.
No. Good. So this is what they have done. They performed an open reduction, formal open reduction, anterior approach to visualize the fracture, to make sure anatomical reduction. But remember, this is 5 days after the injury. And then they secured the reduction with these guide wires, and then they fixed it with dynamic hip screw with anti-rotation screw. They inserted actually 2 screws. What do you think, Imad? Are you happy now? Happy? Good. No? Extensive approach. So how are you going to reduce it without this approach? Wait. So this is the result after 1 year. And this is the result after 2 years. So maybe the injury itself, maybe the bad reduction from the first time, maybe the revision surgery. So it is very important to consider, and this is the 5 years post-op. So now he's a 25-year-old male with this arthritic hip and collapse. So maybe the revision surgery, we don't know, but neck-of-femur fractures are associated with high risk of AVN and should be treated properly in the first place. So in summary, neck-of-femur fractures pose a special biologic and mechanical problem. Quality of reduction is very important, and actually more important than the implant choice. There is no consensus which is the optimal implant to use for fixation. Maybe cannulate screws are good option in horizontal fractures, DHS in vertically oriented fractures, and there are novel technologies might be providing good solutions in some cases. Thank you so much.
Want to do an open reduction. Is it recommended or not to do an open reduction?
Anatomical reduction is the key, open or closed.
Exactly. So that's because that's at the end you gave us a conflicting. So عشان question دوت open reduction is mandatory في حالات النك femur. Now most of the American do open reduction from the start. It doesn't affect the results. ما اقدرش نقول هنا حصل ايه، مش دي السبب.
But there is a time limit for the open reduction in case of fractured neck of femur.
Nope.
You should do it to minimize the risk of AVN within the 6 to 12 hours.
Nope. دلوقتي no evidence of that. That's open reduction. Reduction is a key factor في الريزلتس بتاعت even the blood supply. If you can get it limited, you can do it. But at the end, if you don't get it from the limited approach, you have to open reduction من الأول, whether Watson Jones or Smith Peterson.
Thank you.
I want to ask, in your final result, which was perfect, why did you remove the material? Because there is evidence that following removal of the material, you can have a collapse. I want your opinion about this.
I would remove the material maybe in young people.
Only in young people.
It's not a routine. Yeah.
You have this?
Usually it is not a routine to remove the material.
Exactly, because the advisor.
Neck femur, unless it's causing problem. So if not, I will keep it. I will keep it. Yeah.
I agree with you.
There is no. Yeah. Even AVN is not supposed to.
I do agree. Thank you.
If you allow me to comment on that. So the indication for removal of the metalware, to my mind, would be two. Again, there is no evidence to support that any revascularization is achieved after removal of metalware, but some people have suggested that. However, more importantly, from an arthroplasty perspective, you would want to remove the metal as a preparation for future arthroplasty, because a single stage removal of metal and hip replacement, again, not proven in data, but theoretically has been sort of called off for having a higher infection rate.
I definitely agree with you, but there is some discussion that when you remove the material, the support for the necrotic fragment no longer exists, and therefore they're weight bearing, and therefore they'll collapse. This is well known. We had this even in other fractures without avascular necrosis, where the fracture collapsed in spite of being united. Thank you.
You're right, sir, but I think that in this case, they removed the material after collapsing the femoral head.
No, you're sure about that? How sure can we be?
Yeah, I mentioned about the time.
So I see. Thank you.
Excuse me. What do you think of the proximal femoral osteotomy to transform PAUS 3 fracture into PAUS 2 fracture? Is it worth it? Is it worth everything?
Yeah, valgus osteotomy, valgization osteotomy is an option in femoral neck non-union, yes. And that was only 5 days, yeah.
Again, just for non-union, not in the acute phase.
Not in my hand.
But
non-union, yeah.
Okay, then does it give any problems later for future arthroplasty of the hip?
He will talk about it. Yes.
So just one more comment to say. Thank you, Yazan, for this presentation. Just a small note to drop a note regarding the reduction, which I totally agree with Dr. Zahir on what he said. My name is Akram Shobaki. I'm from Jordan. I'm just visiting with I'm proudly being an AO faculty with these guys. Most of these have given me lectures one day, and I'm so happy to work with them nowadays. So what Al-Zahar said, that you are doing the surgery aimly, the first aim is reduction. AVN is reported as 18 to 21% in cases of intracapsular fractures. Yet, there is another incidence that goes up to 30% in cases with aggressive closed manipulation. So this incidence also dropped again when they moved to open reduction in the cases that really needs open reduction. So yeah, you are exposed to AVN, but much less than you are when you do an aggressive reduction of intracapsular fractures. So the message was loud and clear. First, aim to get a good reduction, no matter what you do, open or closed. The open reduction is the first step, after which you go to the next one, which is think about stability and what kind of metal you need to put in. Thank you very much. Thank you.
Thank you. Thank you.
Whether in children, fracture neck in children or in adult patient, the vascularity is different.
Yes.
Still reduction.
Reduction is key.
And the timing also is very important. Timing.
حاليا الايفيدنس اتغير خالص. الدنيا دي كان موجود كده زمان، دلوقتي الايفيدنس اتغير. موضوع التايمينج بتاعنا اللي خلال 6 hours you have to do it. No, that's have changed. You can do it after 24 hours. You can do it, and you can get. We are not going to leave it forever, but even you don't have to do it late at night. You're not going to do as an emergency and go.
There is a recent paper that came out, a study during the COVID-19, because during COVID, there was a problem in dealing with and operating quickly on patients because you have to screen them, you have to screen and see and prepare the patients, so it took longer time. And then the results were the same. So that's another study added to the previous ones, which shows that delaying them is not a problem. If you are going to prepare the patient, so prepare the patient well, and then take your time. Previously, even they said aspiration to minimize the swelling, and there is no evidence saying that it's advantageous.
Yes, please, Dr. Arnold, floor is yours.
Thank you, but I'm very sad because in the discussion you just was just answering all the things I was just telling you. So I will try to enlighten you a little more. So in a typical fracture like this, of course you would go for closed reduction. It's of course you would, even if it's in an isolated injury. And your decision-making process should include the time of surgery. And the time of surgery is a critical point because sometimes it's very smart to wait because there is no scrub nurse, there is another case, you're tired, I don't know what. So it makes sense to optimize your personal setting. And then what approach is going to be used if you need open reduction? How can you reduce it? Have you tools? Have you some adjuncts? And how should you fix it? So the surgical timing is critical. We all discussed it right now. We feel that trauma should be fixed in between the 6 hours, but it's not evidence-based. It's eminence-based. And the only thing we know is that if you have these fractures fixed more than 48 hours, you face more complications all over. But in between the first 24 or 48 hours, it's hard to find any difference. So, as was mentioned before, reduction is everything. So your first try will always be the closed reduction. And then you have tools, I will show some, and if it's not going to work, you have the open reduction left. But the key is the fixation should always be done after successful reduction. Maybe you know the situations. Personally, of course, I don't know this situation because I can only fix everything closed reduction, of course. If you know it, if you try for an hour or longer to fix it and it's not going to work. And reduction is always the key. So in this case, and we saw pictures before, you can take a cob rasp or something to make a mini open reduction and then a K-wiring and then a reduction with a DHS in this case, for example. Everything you do is as well avoiding complications, and you know them. It's primarily the avascular necrosis and of course the arthritis post-op. As well as the total hip arthroplasty is a matter of surgical procedure in elderly people. What is the problem now? So if you look at this fracture, you have an AP view, an AP X-ray. Do you need a CT scan in these cases? It's smart because if you have a CT, you will see enclosed reduction is very challenging, and if you look at the defect, it may not work. So we are talking about these 31B fractures, of course, you know this. So why should we always intervene here? Because we have this 20% risk of non-union minimum and 20% minimum of avascular necrosis. So the surgical management it's all about reduction. Get your fracture reduced, that's all. And if you ask me, the Watson-Jones approach for the open reduction is smart because you have all the options to go to primary hip, you have good exposure of the acetabulum, and you can go for revision hip. Another case of a 62-year-old with this fracture, you see in the CT scan this defect. what would you do? Would you do immediately open reduction? I don't know. I would try closed reduction, but if you need to open, you can use a shunt screw percutaneously for a joystick, like here. This is a mini open procedure, for example. You can use the direct anterior approach. The pediatric surgeons maybe know this direct approach to the hip. It's okay, you can use it, but if you ask me, it reduces your options if something's going wrong. You can use the Smith-Peterson approach. I would not recommend it because you have to cut muscles. You shouldn't do it, and you have the Watson-Jones approach. And this gives a very good exposure. You can do your incision in the capsule, and you have a very good view to the cup either. So how about the implants? There's a lot of PFN and the blades and the screws and everything, but the fixation technique is not as important as the reduction. The typical sliding hip screw with the anti-rotation screw should be or can be standard. If there is a combination with the shaft, you might need another implant. The proximal femoral plate, for example, it's like the new angle plate. Open reduction and fixation. Or an angle plate with anti-rotation screw, possible as well. Or multiple cannulated screws. And you realize there are full and partly threaded screws. It's not important. You can measure it, that there is any difference between these two. The intraoperative view using a shunt screw again is important. Here in this case with a combination of a femoral shaft fracture, you have to have a perfect AP and a perfect axial view. This is important. If your axial view does not show the same line of the head and the neck, you might face a problem. This case healed, so even in the complex cases there is a healing. It's a young patient, motor vehicle accident, as you can see here, the neck fracture. This is the maximum comminution in the CT scan, and the close reduction is very challenging, does not make even sense. So you would go in this case for the open reduction and of course a condylar screw or dynamic hip screw or dynamic hip plate. But you can see a lot of wires because reduction is very, very challenging in these cases. But if you once have the good alignment, then you can implant the blade and the anti-rotation screw. You have still a gap, but as you can see, it's gonna heal. So how you do the after treatment? The most important thing is you get the patients to full range of motion as possible and partially weight bearing for some 6 weeks. Another case with the neck. You can see here the alignment, which is not so bad, but you face the defect. You would go for a sliding hip screw. You need open reduction because there was this defect. You use clamps for it with this approach I showed you. And then you can use these screw and the anti-rotation screw. The alignment is very nice. And you still have a problem with the reduction, but it's okay. So in the young patients, in very young patients, how can we manage this today? So first of all, in the decision-making process, we should list our potential treatment options. Have we enough screw lengths here in the theater, or are length missing of screws? Have we changed the implant? What options do we have? When do we do the surgery? The pros and cons of the plates is, of course, the pros of the angle plates. There is a very nice compression possible, but of course, you have a problem with the massive approach and the rotation. You need another screw. The cannulated screws, we heard it before, there are pros and cons. So how do we manage it today? We can use this implant. We have injury factors and technical factors for failure. And if you go to the literature and if we look if it's the surgeon or the patient, we see the quality of reduction is the crucial thing. And there are a lot of publications about this context. So a Garden 3 case, quite complex, with a retrotorsion and dislocation here. You see it in the X-ray, but you can see it in the intra-op X-ray as well. You might try to reduce it with your hands. If not possible, of course, you reduce it with some shunt screws. But your aim is always to find the correct alignment. And on the left side, you can see non-correct alignment. You need to do more before implantation. So this axial view, most of the times it's like 80 degrees or 85 degrees. This is the important view. So what is the ideal position of these screws? We just were talking about in the, before. Just to remember, 3 screws is okay, parallel, 1 very posterior. This seems to be most important. And of course, no screw below the level of the lesser troch. This might be the correct procedure. If you use fully threaded or partly threaded screws, it's not that important. So a poor reduction almost always leads to displacement. If you have this case in a young man with only 2 screws, very poor reduction, and bowing screw, you need some revision and immediate revision. And after a year or a year and a half, you will see some success. So the problem might be a dorsal defect zone, as in this case. The fracture patterns in the young patient, they have a better bone quality. They suffer most from high energy trauma. So the open reduction in young patients might be more option than in elderly patients. A case of 3 screws after a skiing accident, a very nice position, and you see it's healed, fully healed, and there is not much osteoarthritis. So this is an option even if you do open reduction. So my take-home message is only once, get it reduced. Thank you. Are there any questions or comments? Please. So the question was, what do I think is the reason that I lose reduction on the table? Is that correct? If yeah. Yes. Mm-hmm.
So what is acceptable as a reduction failure and what is not acceptable as a reduction failure? These are key points.
You can ask me what I feel, what is acceptable, because as you saw, a lot of fractures heal even if there was a surgeon on site. So it's the reduction key is according to the implant as well. If the implant, and I think that's the question you wanna go. If the implant is not inside correctly, then you have a risk for non-union. That's what you wanted to say.
I think the important thing is that when you're reducing this fracture, you need to make sure not to compromise on the device that you're using. You see, you've shown us x-rays in which you've had a step off, but you used a rigid device.
Yeah.
Which stopped vertical shear. So what a surgeon needs to judge is preemptively what fractures would fail with what device. And that can be judged. That is important. Because when I go to a ward run, if my SR is operating, I sometimes say to him, were you in a rush? Did you want to finish the operation very quickly? Because reduction takes time.
Of course.
And you need to judge very carefully, because in most trauma centers, you have a choice of implants. You have cannulated screws, you have PFN, you have DHS. Now, the judgment call is that you reduce the fracture, and you can reduce most fractures, close reduction, but where the failure happens is when you put the implant in, and you go back and look at the X-ray, you have a step off.
Yeah. But maybe you saw some images with a lot of K-wires, even fixing the K-wire through the head. So in my...
The K-wires, let me come to that. The K-wires are threaded K-wires. So when you put a thread, the K-wires are threaded K-wires.
No.
Quite a few of them, especially the lower ones were threaded.
For a reduction?
For the cantilevered screws, when you put in,
for the screws,
they're
but
threaded.
for the reduction, they're not threaded.
Yeah, but what you need to do, when you put the cantilevered screw in through a reduction K-wire, which is a threaded K-wire, you will not achieve reduction. You need to make sure that your first K-wire is such that when you put a screw in, it does reduce it and it holds it.
Yes.
If I may comment here, sometimes the image itself is misleading. Image intensifier sometimes is misleading, and that's very common. When we had a cadaveric lab about the fractured neck femurs in Davos, we had a competition between the Americans, one American and one from Germany. The American are pro open reduction from the start. 15% of their cases are closed reduction, but mostly are open reduction. So they challenge each other. And in the lab, they made a fractured neck femur, and the guy from Germany did a closed reduction, and on the image that was perfect. And then he put his fixation or temporary fixation. Then the guy from USA opened it, and he found a step and even a gap. And on the image intensifier, it was quite well. So that's the idea from the guy from America that they love to do it an open reduction, and most of their open reduction they do it from the Smith-Peterson with the vertical lip or Hoyt, yeah. But it works both ways, whether Watson Jones or Hoyt. So that's the way you see things. So that's the conflict between both techniques. But at the end, the idea is reduction, whatever the way is.
But basically, the rate of open reductions in my hospital, for example, is really, really low. So most of the cases can be managed by closed reduction without any problem.
May I ask a very humble question? My question is that when you get these fractures, these transcervical fractures, whether Powell 1, 2, or 3, and you put cannulated screws, you put them parallel, 3 parallel ones, and at times there's a newer technique where they put 1 transverse. Now, we know according to the basic principles that there is resorption at the fracture site. So, my question is, what do you do to avoid a significant collapse and a change in position of the fracture fragments?
In these cases, fully threaded screws and non-weight bearing is really a nice option. Full range of motion, no weight bearing. And if the reduction was okay, after 6 weeks, you rarely see dislocations.
You rarely see. And you don't see any resorption at the fracture site.
You know why? Because most of the cases are younger patients, are quite healthy patients. Usually in neck fractures and elderly patients, we relatively fast go to arthroplasty. That's why.
Thank you.
Excuse me. The first is an inquiry, technical inquiry. You have mentioned the joystick phenomena of Achans. I like the idea, but I want to know a technical advice from you. How can you utilize a bulky metalware through the neck while you are occupying that neck with a bulky Chance screw to make a very good position? How can you tell me how can you achieve this in the same time? Because you will hold reduction as a closed reduction with the joystick, and you have to pass a metalware like DHS, for example.
Yeah,
It's
but
a bulky one
you
through the
reduce
same
it, and if you use a shunt screw to hold it, then you can wire it, and then remove the shunts, and then you can...
Is it through the same neck? If you remove the chance, the joystick phenomena will not achieve your perfect reduction.
No, not really. No. Yeah. Exactly, then you remove the shunts and then you're fine.
Second notification is, I have seen through the presentations that have been mentioned now, I think the displacement that necessitate close reduction or open reduction is the rotation. And I've seen the osteoarthritis that I have seen in almost all the X-rays was an femoral-acetabular impingement syndrome. I think this is a rotation failure, and this is correctable in the early, because this is a late osteoarthritic changes due to the impingement, due to the malrotation position.
That's correct, but
Thank you.
You need a patient who is willing to get a correction osteotomy, for example, and this is will be a problem. Most people, they go for total hip then. Yeah, if I see that that there is a problem and there is a rotation failure after, let's say, 6 weeks, I have to convince the patient for another surgery. Difficult sometimes. Thank you.
So, when and why arthroplasty? Just to remind, this is one of the biggest diseases of the modern time. It represents 30% of all hospitalization, with significant morbidity, mortality, and expense. So, is marked human in elderly population. And as Dr. Yazan said, the most important element in anatomy is the blood supply. So after fracture, blood supply depends only on reticular vessel, and with greater fracture displacements, there is greater risk of reticular vessel disruption and avascular risk of necrosis. So the CT scan is indicated in non-displaced fracture, and the MRI in occult fracture. The most common classification that we use is the Gardner classification that evaluates the risk of vascular disruption, and the Powell classification that related to biomechanical stability. So, the aim of the treatment in geriatric patient is to mobilize with the weight bearing as a tolerate and minimize the period of bed rest. So, to minimize the surgical morbidity, safest operation, and the most important is to decrease the chance of reoperation. With the young population, the aim is different. So, we aim to spare the femoral head, to avoid the deformity, improve union rates, and optimal functional outcome, with minimizing the vascular injury and to avoid the avascular necrosis of the head of the hip. So, what option do you have? Non-operative option is a limited role with high operative risk patient indicated. Reduction and fiction is as open or percutaneous as previously said, and the arthroplasty, EMI or total arthroplasty. Our decision is related for the patient factor, young and elderly, the velocity of energy injury, association with other trauma, with the comorbidity or pre-existing hip disease. The characteristic of fracture, so is we evaluate the displacement, the stability, the Powell angles, and the comminution, especially posterior-medial. So, the treatment issue with the fixation, we have lower surgical risk but we have higher complication rate and higher risk for reoperation. With replacement, we have higher surgical risk with fewer reoperation and better function. So, for the treatment for the undisplaced fracture, Guardian 1 and 2, with low risk of developing avascular necrosis, we choose the conservative treatment that gave us more than 95% of union. With displaced fracture, for the patients that are less than 60 years, reduction should be attempted and must be sufficient to convert the displaced fracture into the undisplaced variant. With the older patient superior to 60 years, we choose often the arthroplasty, EMI, or total arthroplasty, independent the patient. So why arthroplasty? So with replacement in elder patients superior to 60 years, it gave us less complication, 4%, less revision surgery, and better functional outcome. So to summarize, intracapsular hip fracture with the non-pathological fracture with less displacements as Guardian 1 and 2 should be done, we should use, sorry. So we should have a conservative attitude with the Guardian 3 or 4 with the physical age superior to 60 years. We should use hemiarthroplasty or total arthroplasty. And thank you for your attention. If there are any questions.
Hemiarthroplasty or total hip arthroplasty? And if you decide to do you do cemented or non-cemented?
So it depends on the bone quality. Is very arthritis associated with the fractures or not? So if you have a patient that over 80 years, for example, we choose hemiarthroplasty is he don't have an arthritis associated. Cemented or not cemented, it depends on the bone quality. If there is a potential of osseointegration, we use non-cemented implant. If there is no potential, we use cemented implant. So it depends of the bone quality.
Can you return back to the last slide? No problem.
La présentation, brother?
The algorithm, yes. The question is, if we had 3 or 4 garden fracture.
Présentation, trajan la présentation.
In 3-4 garden fracture, and when you found posterior teeth which is greater than 20 degrees, we go straight to arthroplasty in young adults.
Yes.
So you support this
yes, because
straightly.
Because the risk of avascular necrosis is superior to 95%. So if you have only 5% chance to have a conservative treatment.
Thank you.
Thank you. Okay.
Can you get my talk up, please? Good afternoon again. Post-lunch, difficult session, a lot of parasympathetic overdrive, with a lot of food. The food has been absolutely amazing in Tunis. Thank you so much for the hospitality, and I can't see Sofian Khalel here. Thank you again for inviting me. So luckily we don't have technology glitches like we did yesterday. We spent a very busy day yesterday. So Arnold, my friend, he just said, I'm sad because Yazan had already spoken about, about 25% of his presentation. You can see my tears on the floor because the previous 3 speakers have spoken about 70% of my presentation. So that makes my job actually quite easy because most of the principles have been discussed. And obviously, all of the tips that were alluded to by the previous speakers actually are prevention of complications. And the best treatment for treating complications is by avoiding them. So the learning objective from my talk will be to enlist possible complications, discuss prevention strategies, explore potential salvage options and their limitations, and then discuss reconstructive options, which are, to a lot of us, very limited again. So we all know that these fractures are fraught with a high complication rate, and the 2 most common complications are osteonecrosis and non-union. There have been varied reports in literature, sort of a meta-analysis by Mohit Bhandari did show that whatever you do, there's still a 15 to 20% reoperation rate, and these are isolated femur fractures. We're not even talking about femoral neck fractures associated with shaft fractures, associated with multiple system trauma, as in polytrauma patients. So there's also a problem with femoral neck shortening. If it is less than 10 millimeters, it is sort of easily tolerated, but if it is more than 10 millimeters, it is associated with worse functional scores, and patients don't like it. There can be cases of implant penetration. There have been cases of screw backouts and also implant breakage. So why do these complications happen? And we've already gone through all of these factors. It's high energy trauma. They're usually associated with other injuries. We know that there's a high complication rate because of this. We've discussed timing. Obviously, we have gone out of the era talking about the 6-hour window, but still timing is important because more than 24 hours delay in reducing and getting a fixation has been shown to be associated with poorer outcomes. So again, what implants you would use? Whatever you use. AO screws, pins, sliding hip screws. Pins has absolutely got no role in the modern management. It is a thing of the past and probably reserved to history books in orthopedics if you just use pins for fixing these. I know in my exam back in Pakistan, when I did my FCPS exam, there was a Noel's pin, and I had never seen it before. But luckily, I had some mentors who had taken me through some of the old Jewett nails and the Noel's pins, and we had a museum of these. But luckily, I knew the answer to it. Obviously, there have been intramedullary implants that have been used. Essentially, they function. If you use a gamma nail, it will function like a sliding hip screw. You can lock it, and then it becomes sort of a fixed angle device, if you can. Yazan also referred to the FAITH trial, and obviously there's a FAITH 2 trial, which was a randomized control trial comparing sliding hip screw versus cannulated screws. And obviously you can see whatever you do, if you don't get a reduction, your complication rate remains fairly high, which was the same finding of the FAITH 1 study. This is an old slide, and obviously subsequently there have been some newer studies, especially the one that Dr. Khoshal mentioned that was in the COVID lockdown, which also had the same findings as Duckworth in 2011, which said that more than 24 hours after surgery has increased failure rate, but you do not need to take the patient overnight to theatre. There is no advantage of doing surgery overnight, and the 6-hour window has been thrown out of the door. So in fact, it is probably increased with higher complication rates because you have got a junior person operating with maybe in an austere situation with not much help with a junior radiographer in theater and a junior scrub nurse in theater. So it's not ideal. And you can always do it as the first case on the next morning list. And I think that's sort of the accepted norm now. So how do I manage my complications? The first thing is you need to avoid them. And to avoid them, you need to speak to the first 3 speakers. In fact, the first 2 speakers, how to avoid them. So meticulous surgery, reduction. So where would you do open reduction internal fixation? Where you cannot closely reduce a fracture using your closed maneuvers. Then have no hesitancy in opening up. Because if you don't reduce the fracture on the table, that is the worst, that's the biggest disservice you've done to the patient. The bone has to be of good quality, and there has to be no evidence of osteoarthritis. That is when you will go for internal fixation. Otherwise, I will bring to the discussion of actually doing a primary hip arthroplasty even in younger patients. So reduction, 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 whatever you do, and you've seen these pictures before, so I'll quickly go through these. It is always the reduction. And don't forget reduction in the lateral view, which is the retroversion of the femoral head, which is quite often neglected when people are reducing. So it is reduction not only in the frontal plane, but also in the sagittal plane. That is important here. So anything more than 10 degrees of retroversion is unacceptable. So you've seen this slide before. Again, always consider that there is a rotational element to the injury. You have to make sure that your femur is pointing in the right direction on the traction table, and you have to make sure that the posterior medial calcar is aligned and you don't have any retroversion. So as my friend Yazan alluded to me, very similar case to yours, Yazan. What would you do? And what went wrong and why? How old? So this patient is 25 years old. This is a 6-month follow-up X-ray.
So, 6 months. I would remove the screws and do the valgus osteotomy.
Are there any other options? How many of you would do a valgus osteotomy just like Yazan? Raise of hand, show of hands. So 1, 2, 3. How many of you would do something else? What would you do, Dr. Jalidi? Revise the fixation. Yes, an option. Revision of fixation. Make sure there's no infection. Anything else you would do? Who's considered about viability of the head? Would you be worried at this time? And how would you, what makes you think, what do you see on the X-ray? What would you look for on the X-ray? So it's non-union, not AVN. Yes. At present there is no AVN, but we've seen the case from Yazan that if you sort of go in and remanipulate this, you can still have AVN. So I think from a medical legal perspective, it is important to even document that there was no AVN when you started your revision surgery. At least that's sort of the dictum we use in the UK. So what is the ideal investigation for that? It is again controversial, MRI versus bone scan, and now there's obviously the SPECT CT scan. I think in Oxford we quite like to use the SPECT CT scan because, I mean, it's difficult with the MRI. Unless you get a very good metal subtraction MRI, you would not be able to pick up any signal change. It's very subtle changes. So SPECT CT scan is something we quite like to use. And this was a fairly recent paper published just last month, which showed this got a high sensitivity and specificity. This paper had obviously patients with failed fixations, but also patients with primary AVN with no femoral fractures. So this was actually, so the case mix is different. But it is a good investigation. So I think my treatment options will be divided into if the head is viable and if the head is non-viable. So if the head is viable, then we have got an option of salvaging this. This is a salvageable situation, and then you've got certain surgical options which you can employ. If the head is non-viable, then obviously there is no chance of salvage, and you have to think about replacing, reconstructing, whatever you're comfortable doing. So let's talk about if the head is viable. If the head is viable, revision ORIF. So revision ORIF, at least in I haven't got a lot of experience with revision ORIF, but Yazan had just shown a case of revision ORIF, especially in the acute setting where within 5 days the fracture had collapsed. There's Mr. Bob Handley, one of my trauma gurus in Oxford, and he quite likes to use these plates on femoral necks, not only as primary fixation devices, but also for revisions. But again, in this case, you need to have, these fractures are fairly simple. They're, as you can see, they're Powell 1 and 2. But again, this was a follow-up which didn't go to heal, and you can see that fracture gap there, and he's revised it with a medial plate. And that was an anterior plate which he used to add stability and compression on that. Personally, I've not done this before, but to me, revision ORIF can be done with limited success rates. But you have to make sure that you have good biomechanics and, again, good reduction. In this case, the fracture had not displaced, and obviously there was a device in situ, so it was quite nice to just do a plate over it and get away with it. But if you are going to formally revise fixation, then you have to consider what approach are you going to use, what is the implant already in situ, what was the approach used in the previous surgery. If this fails, what will be your salvage options and what will be your reconstructive options? And if you are going to plan for a hip replacement, or you're looking at a hip replacement 2 or 3 years down the line, how your new intervention is going to come in your way. So removal of hardware, revision of reduction, and then obviously how you're going to get new bony fixation, and whether or not you're going to use any bone graft to impact into the non-union gap. So it is fraught with complications. As we saw, you can actually produce AVN by your revision fixation, and you can still have residual limb length discrepancy, especially if you compress a non-union. You will further have neck shortening in this scenario. The other option, which is my favorite choice for most of my revisions, is your valgus osteotomy. It is quite a nice operation for most of the pediatric surgeons. They do it all the time. Even for trauma surgeons, this is the 120-degree angle blade plate. And essentially, you are converting a Powell 3 into a Powell 1 or 2. So you're changing the angle of the fracture, and you're converting the shear forces into compressive forces. It has a high union rate reported in literature, up to 95%. That's the highest by far for any technique that has been employed. So again, it's a biomechanical problem, and you restore the biomechanics and the fractures will heal. Finally, obviously, I have got no personal experience of using muscle pedicle grafts, but I've worked with people who have, and one of my previous mentors quite liked to use the Mayer's quadratus femoris pedicle flap. It is a tedious operation, but again, you have to get your biomechanics right, only then the biology will work. You cannot expect the biology to work in a poor biomechanical environment. So you have to get your angle right, you have to get your reduction right, and then your graft will work. You can't have a varus collapse of the femoral head and a retroversion and then expect to have union by just doing a pedicle graft. Whether you use a Mayer's graft or you use an Ilia crest pedicle graft, whatever you want to use, you need to get the biomechanical environment right. So if the head is not viable, then actually your life becomes really simple, because then you have got just one option. What is that? Vascularized fibula. So there's always controversy. Controversy comes before solutions. So vascularized fibula. How many people have used vascularized fibulas for femoral neck non-unions? And what have been your results? Not good. Not good. So when you have a non-viable head, yes. We're not talking about just, we're saying if there is a non-union, but we have a non-viable head. So we have an AVN,
with a non-union. I'm not talking about this particular scan. So we're just talking in terms of if you have a situation where there has been a non-union, but now you also have a non-viable head. Remember we spoke about the SPECT scan. So if on the SPECT scan you investigate and you have a non-vascularized head, what do? Do you put in a vascularized fibula and expect it to revascularize the femoral head? Would that happen? We don't know. So I think the evidence has gone sort of against it. And in most modern health systems, you would go for sort of a hip arthroplasty. I'm just showing this one slide because I created a lot of controversy in the room in the morning, which was with Ilizarov hip reconstruction. Again, for very small select group of patients, this is an option. In rural situations where they cannot accept a hip arthroplasty for X, Y, or Z reason. I do not want to create controversy in this room, but again, I have personally treated 4 fracture non-unions with a non-viable head with this technique with sort of good results, but these patients did not accept a hip arthroplasty, and that is why we had to go. So there are alternates, and that's why I quickly showed the slides. Obviously, in my hands, the safest option is to do an arthroplasty if the head is non-viable, and most literature in the current time would agree with that. Again, what type of fixation you would use on the femur? There was a question to the speaker earlier. It all depends on your practice, on how you've been trained. In England, everything is cemented. In America, everything is uncemented. But yes, there are definitely some things that you need to look at. You need to look at the size of canal. You need to look at the bone quality. You need to be sure that you're not going to create a fracture, and you can't have uncemented fixation in a door 3 or door femur with a large capacious canal. However, in a younger patient, I would always use high performance bearing, and in my hands, ceramic with a highly cross-linked poly is sort of my ideal go-to solution rather than a ceramic on ceramic. Although technically that is better, but this is sort of the right balance in terms of cost, and it gives the coefficient of friction is not very different, and obviously you avoid the problems of squeaking. But that is for an arthroplasty talk at some other time. We're discussing trauma now. To just throw a bit of fire at the end, I'll sort of talk quickly about this cost-benefit analysis that was published not so long ago in JBJS, and this is from Massachusetts. So they found that in a displaced neck or femur fracture, this primary treatment. It is not treatment for non-union, this is primary treatment. They sort of thought that, if you start off with a hip replacement in these patients, they had better results in terms of total cost to your healthcare system. So if you have a healthcare system where the government is paying, you might want to refer to this. I don't think that's the case in Tunisia. So patients do pay out of their own pocket, and then obviously we stick to AO principles, and this is an AO symposium, so I wouldn't go there. But this is just to generate some discussion. Thank you. Any questions? Yes, Yazan.
Tips and tricks about this medial plating. Tips and tricks how to do this medial calcar plating.
About the medial calcar plating. Well, again, as I say, I don't have a huge experience with this. I've just seen it on a few occasions. What it does require, so basically what you're trying to induce is a rigid environment, and you're trying to increase stability at the fracture site, and that's the treatment for non-union. So the trick is you need to have an implant the prerequisites are you need to have an implant in situ, you need to be reasonably happy with the reduction as it is, you do not need to revise your reduction, you should not have a cortical step off, and all you're doing here is to sort of, add that plate. The way I have seen it being used is through an anterior approach, which is Smith-Peterson.
So you take the leg in figure 4.
Yeah. Anterior approach, take the leg in figure 4, and then fix it. It's a tedious operation because you can't get all the views when you're doing it. You need to have a really experienced radiographer, and we often like to use our spine table to do it because that gives us a radiolucent sort of picture. And then if you rotate, then your sidebars are not. So it's difficult to get images. I think that's the technical point. It's difficult to get the right images, especially when you're placing the plate. But if you've got a good reduction, then you can use your anatomical landmarks to put your plate right at the sort of at the center of the calcar. So it has to be center, and if you want to err, you have to err posteriorly.
Does this approach in which you put a medial calcar plate, does it compromise the blood supply? Because you see, the blood supply to achieve a dissection, I've never been able, I mean, I've done grafts and things, and I've done the Myers. You don't actually see the medial circumference artery supplying the capsule. It's very difficult to visualize it. But how do you know that you're preventing the blood supply being damaged?
So if you see, the blood supply is all in the anterior approach. Once you've done your capsulotomy, which is your anterior approach anyway, all you're doing is rotating the femur so that the neck faces you in the anterior approach. So you're not sort of, extending your dissection too far down across medially. It is the same inverted T, and it gives you enough exposure. Once you put the patient in a frog leg position, a figure of 4 position, the neck sort of rotates in your view. So you don't need to excessively dissect. It is the same standard Smith-Peterson approach and the same risk of avascular necrosis as of a standard Smith-Peterson approach.
With this medial calcar plate?
So this can only be done with the head is viable. Oxford Bob Handley has published his own series, I believe, of 15 or 20 cases, and he has had 3 conversions to a hip arthroplasty. So that's the same number that you get for all revisions. So, 3 out of 15 is sort of what, 15%?
Okay.
Which do you do first? You put the medial calcar plate? You put the medial calcar plate first and then do your reduction, or you do your reduction and then you put your medial calcar plate?
So that depends on what the problem is. The 2 cases that I've shown you had no problems with reduction. So the medial calcar plate was just put to increase the stability at the fracture site and make the whole construct more rigid. If you are revising it and you need to use a medial calcar plate as in you're going to remove the original metalwork, then again you need to ensure that what is the indication of using the plate. Are you just using it to create a stable construct, or are you using it to reduce? Because it can also be used as a reduction plate. So you can reduce the fracture, as in reduce the medial cortex with your plate, and then put in your screws or sliding hip screw. However, that to my mind should be extremely challenging, because then you've got the plate screws and you have to put a big lag screw through it. So it will be very, very difficult. So I think temporary fixation with K-wires, just like Arnold showed, will maintain the reduction. And if you still think, because when you're revising, remember you've got problems with bone loss, and your new lag screw might not have enough bone to hold on. So you can sort of, add more stability to your construct by putting on an additional plate.
Thank you.
Yes.
Are we confident to MRI to guide us to the viability of the head femur? Viable or not viable to take the good decision?
So that is, as I said on my slide, still very controversial. We don't use MRI anymore in Oxford, especially for femoral fracture AVNs, because there is pre-existing metalwork. And the advantage of using a SPECT CT scan is it not only gives us answer of the biological condition of the femoral head, but it also gives us a CT scan, which you can use to assess your current fracture configuration and plan your revision surgery. As far as using MRI for primary AVN not in the setting of femoral neck fractures, I think it's still applicable. But no studies have actually shown, there's just one or two recent studies that show that SPECT scan is better. But it also depends on, have you got SPECT scan available? If you don't have a SPECT CT available, then MRI is your option. But try to get at least an MRI with metal subtraction, because otherwise you won't be able to see anything in the subchondral bone as any sort of any signal change in the subchondral bone, which will sort of show you the whether there is or there is not AVN.
Do you use any index or scores to evaluate the reduction after the reduction of the fracture?
Sorry, any?
Any index or scores, like Lowell scores or index of Garden?
I think for research purposes we do use it, but on the day of the operation it is all in the hands and eyes of the surgeon. So you have to make a judgment call on the day that you need to have your cortex checked. You have to have absolutely align and reduce cortices. People talk only about the calca and the posterior medial cortex, but I think if you consider the first lecture as well, it was all about getting reduction in all planes, getting reduction in the frontal plane and the coronal plane, and that's what you should aim for. No retroversion is acceptable. Anything more than 10 degrees is fraught with a worse outcome. So have reduction on the day, on the table, and you'll be fine. Remember, there's still a high risk of complication. Whatever you do, you try your best on the day, and then you leave the rest for nature to heal.
Thank you.
Do we have time for more questions? There are more questions coming in. Yeah.
Okay, Mohammed Madani from Sudan. I'm an orthopedic surgeon. I would like to ask about the bone graft, to use the bone graft in when we have non-union with viable head. You revise the fixation either by medial calcar plate or not, but for every case we have non-union, we need to do a bone graft.
Not for every case. Not for every case. I think, you see, bone graft, you have to, it's again like treating any other non-union, like in the femoral shaft or femoral neck is no different. You need to know your indications of using a bone graft and what type of bone graft are you using. If you're using bone chips, for example, which is the readily available to us, we are basically using it to fill a void. So if there is a gap and you need to fill it, and you're actually depending on creeping substitution, then all you need to do is you do that. But if you want any biology, then obviously you've got muscle pedicle flaps. You can use the iliac crest and you can use Mayer's pedicle flap to add biology as bone graft. But again, you still have to revise your fixation and get it right and restore the biomechanical environment.
Okay, thank you.
Thank you so much.
Good evening. So now we will talk about the pediatric femoral neck fracture. So it's uncommon in pediatric population. The incidence is about 0.3 to 0.5%. It's due to a high energy trauma, and this fracture is known to have a high complication rate. So we have some case. The first case is a boy 4 years old, fall from high, have a pain and with impotence, and in the X-ray we see a Salter 1 fracture, and in classification Delbert is Delbert 1. So what we can do for this boy? Orthopedic treatment or surgical treatment? Closure reduction. So it's a closure reduction with key wire and spica plaster with a good evolution. The second one is a 12 years old boy, traffic trauma, isolated hip trauma, and there are a fracture of the neck. It's Delbert 2. So for this patient, the closed reduction was, we haven't obtained a reduction, anatomical reduction, so we go to open reduction. It's Watson-Jones approach, stabilization with spica, with the screw and spica plaster, and we have a good evolution at a follow-up of 4 years. And the third case, it's also a male, a 13, traffic trauma, Delbit 2 also, and we have a close reduction and percutaneous fixation with a screw, but at 2 years, we have a vascular necrosis of the femoral head. So if we can talk about the pediatric fracture, it's important to talk about the Delbit classification system because it's important. It led to guide the management of the fracture and the risk of vascular necrosis. The overall goal of the treatment in pediatric patient is to have anatomic reduction and stable fixation. The anatomic reduction can be laid with a closed reduction, but with gentle maneuver. Don't exceed the 2 tentative. If it's not possible, open reduction is permitted, and arthrotomy can have a decompression of the hematoma that decrease the hyperpression in the hips and lead to anatomic reduction. The approach is anterolateral approach, and for the stable fixation, it can be a problem. For young patient, we can use the key wire, especially very young patient, and we must add the spica plaster. For the other 2 or 3 cannulated screw with washer that we have stability and compression. We recommend the spica plaster because in children we can, to avoid the second displacement. The problem for the adolescent or overweight old children, we can use pediatric dynamic hip screw or pediatric plate. What about cross and growth plate? In Delbit 1 and Delbit 2 fracture, it is permitted to cross growth plate or not. So it's necessary, if it's necessary in this 2 fracture, in young people we can use the key wire. For all children 12 or 11 years old, the balance between stability and compression of the fracture and the grow arrest, it's important to evaluate. Shortening about 1 or 2 centimeters, it's not very bad for a pediatric population, but pseudarthrosis, non-union, it's very bad complication. So the complication, the most important complication is the vascular necrosis. The fracture in pediatric population, it's known to have a high complication despite appropriate diagnosis and management. And this complication can have potential long-term disability. So for the avascular necrosis, it's correlate to the initial displacement and the type of fracture. And the timing of surgery and capsulatory or joint aspiration, it's not very important in the literature, but a rapid treatment is important. So the follow-up must be long, minimum 2 years. So my take-home message. The orthopedic treatment is only for a displaced fracture in young children. We must have an aggressive management, anatomical reduction, and stable fixation. The open reduction, it's possible in pediatric. The most important thing is to have the anatomic reduction. And thank you. Oh, yes.
I just want to make one comment. You know that most of the growth in a child grows around the knee. Only 7% grows in the proximal femur. And you are quite justified to put a pin across the physis in a 12-year-old boy or girl, more for a girl. And this is much better to a non-union.
Yes,
And that's a very important point you have put.
Yes.
But I wanted to ask you one question. Isn't the overall rate of avascular necrosis 45%? Because it's quite high reported in the literature. So I want to know about that. You put 20 to 30%. You're generous.
In the last article, a paper that I found is between 20 and 30.
Good.
But I know that it can, in some publication,
higher.
more than 70%.
Thank you.
Taking the hematoma out of the capsule made a difference.
For aspiration? No.
On an acute setting, and you take the hematoma out of the capsule in a young person, did it make an overall difference?
Personally, I don't know. In our practice, no. But in the paper, the review of the literature, there are not a very statistically correlation between the aspiration and the vascular necrosis rate. Some author report that it's better to have this aspiration, but not there are not a statistical proof of this method.
Because in many cases in a child who suffered this sort of injury, it's usually a very high intensity injury. It doesn't happen by simple, it's a very powerful injury. And sometimes, you know, if you have to delay something, the simplest thing you can do is just aspirate the hematoma and wait for the child to become better when you do the surgery. Just something. In a multiple trauma situation, sometimes you minimize your risk factors, and you try to do things to make sure that your end result is better.
Okay. There are any questions? Okay. Thank you very much.
We've had an experience with resurfacing, and we've had some complications. One of the complications was that we had late fractures directly at the junction of the head component with the shaft. Another point, are there any limitations for this procedure? If you get a patient with a narrow neck, would you still do it?
Yeah, it's a great point. And of course, you're absolutely right. That femoral head, we know, I think in men, we know that the 15 and 20 year results, I mean, on my personal results, there's a group of us published the 15 and 20 year results in men from around the world. It seems to, men's hips, femoral head bone seems to be strong enough. I think you're absolutely right. To be concerned about femoral head viability in small femoral heads in heavy people, particularly. So I don't think this is right for all women. I definitely don't. But to say to a 25 or 30 or 40-year-old woman, I'm going to cut your femoral head and neck out because I know it'll be better for you than trying to do a resurfacing. Well, I don't know that right now. And it seems like it's a reasonably conservative trial. It's a trial. You know, I'm definitely not promoting this. We haven't got a CE mark yet. It's ongoing work rather than the finished product.
Thank you.
So Justin, what's your ideal indication for this then?
Someone who enjoys activity, I think is the indication, with good bone stock. I absolutely think that comment was right. You know, femoral head bone, if it's not strong, then it won't respond well to this. But the periprosthetic fracture in total hips is not zero. that story is not over either.
Sure. Any further questions from the audience?
Yes, if there is a problem with the offsetting, is there any argument you could actually add in order just to make actually the two pieces are in contact?
Currently, this is just resurfacing. It's not changing the rules of resurfacing. The only thing it's doing differently is taking away the metal. Really?
But sometimes in cases of rheumatoid, for instance, younger patients, there is a problem sometimes with the acetabulum where it is really quite friable, sort of fragile bone.
Yeah, this is not for them. This is in dysplasia, this is very good in dysplasia. Because even though they're deficient superiorly, there's always bone posteriorly. So in even quite bad dysplasia, this is good. But rheumatoid, I agree. We need all the tools at our disposal for rheumatoid. That's a really hard problem. This is not designed for that, I'm afraid.
Thank you.
I wanted to have an idea about the age range of your patients. And
so far we said less than 70.
And the second question, your follow-up and the rate of revisions for your procedure.
So far we've had 3 fractures. One man was skiing and a snowboarder took him out at high speed. He broke his femoral neck. And of course, that's a revision. So we've had, and a tennis player went back to playing tennis 6 weeks after surgery and broke his femoral neck. So we've had revision, of course we have. Everybody knows a femoral neck fracture is a problem, but the treatment is just putting a femoral stem in with a dual mobility head. So it seems like although the fracture risk is higher, the treatment is quite mild. It's just having a primary stem with a dual mobility head. But it's not the answer to everything. It's just, I'm not promoting it as magic. I'm just saying it's what we're up to right now.
Thank you very much, Justin, for your time and for waiting as well. Thanks a ton. And we'll crack on with the other talks. Thanks a ton, Justin. So could we kindly put Professor Maureen Penner's video on now? Thank you.
Good afternoon, everybody. My name is Oliver Marin. I'm orthopedic surgeon from Madrid, Spain. And it's for me a great honor to participate in this Tunisia meeting, in this CICOT symposium. These are my disclosures that do not affect the following presentation. Our objective with this 7-minute presentation is to identify the benefit of this ERAS protocol, establish the current situation in my country, establish the main barriers to develop the ERAS protocol that are hip and total, and the future tools to improve this ERAS protocol. As an introduction, a video is much better than the word, and I will show you a short video of how the patient see this ERAS protocol.
Hey there, Dan.
Okay, Jane, how's it going?
Oh, you know, I'm getting better after my surgery. The doctor says I'll still be here for a few days. What was that?
Hey, good to start.
Why are you guys going so fast?
We're on the fast track. Why are those guys going so fast? And what's the fast track?
Oh, you must be the fast track series. We call it ERAS. ERAS? Yeah, it stands for Enhanced Recovery After Surgery. Awesome.
Well then, next time I'll have surgery, I'm having it on ERAS style.
I'll have my skateboard ready. Alright, back to work.
So that's the point of view of the patients, and now all of them take this skateboard to move. But at the beginning, this was not the main role. The patient was not the main role, and this in 1983 started as clinical pathways in the US. And the main focus of this procedure, outcome, and finally the economics is the topic, and they try to standardize total hip and total knee procedures, optimize them, optimize the outcome, and finally do an economic saving. So the money was the main focus of these clinical pathways in 1983. In 2000, in Denmark, this general surgeon, Henry Klett, established these fast-track protocols. And for orthopedic surgery, Henry Hansen established this protocol. So the main focus with these new protocols in Denmark was the procedure and the outcome, focused on reducing the surgical stress of the patient and reduce the length of stay. What is the situation in Spain actually? We established this study, this prospective study, in the 90 days complication in 130 hospitals with these HIRAS protocols or not. And we saw that the HIRAS protocol reduced 1 day the length of stay in hip and knee. And if we focus in the hospital that say that they are doing HIRAS, we can see that there is a huge diversity in the length of stay. So length of stay is not the main issue to do a HIRAS protocol. How to do it in your hospital? How to jump these barriers to develop this protocol? Well, these cornerstones actually are four. To do an action on fear and anxiety of the patient, and I mean in the surgeon also. To do an action in complication and comorbidity. Do an action in treatment side effects. And finally, try to reduce the number of surgeons that say, I always did in that way. So let's see how we can manage that. How to reduce the fear and anxiety of the patient? Well, we can do a pre-ready patient education with different tools, group of meetings, information in paper, different calls. How to reduce the complication and comorbidity? It's very easy. Doing a good patient selection and try to optimize the patient before surgery. What about the side effects? How to reduce that? Here the anesthesiologist has an important role with the multimodal pain approach, with the tranexamic ASIC, who was a great change in our surgeries. Don't use drain, don't use urinary bladder catheter, and avoid opioids. And what about this problem? The surgeon will say that I always did it in that way. To be honest, I don't know how to manage this situation. So let's see why everybody win with this HIRAS protocol. The patient reduces the surgical stress and improve the outcomes. The surgical team reduce the risk and increase the quality and improve the outcomes as well. And the hospital reduce the cost, increase the quality, and increase the efficiency. What about the future tools in these HIRAS protocols, in total hip and total knee? We used to do this relation with the patient in person, but with the COVID era and digital technologies, everything has changed. We can use these apps in your cell phone and try to connect with the patient with this pathway through their smartphones. You can check the pain of these patients. You can check the activity of the patient with this pedometer. You can put videos just to increase the information of the patient and reduce the stress. And also send the patient questionnaires, hip and knee questionnaires in different scheduled dates. So the take-home message: HIRAS protocols improve the patient care through patient education, patient optimization, and the multidisciplinary approach. And the future new technology can improve this relation and make it easier and cheaper. Finally, I want to invite you to our meeting, our second meeting in Kuala Lumpur, Malaysia next September. Thank you for your attention.
Thank you very much, Oliver. That was an excellent talk. Any questions from the audience? I've got a clear message from Sofian Khalil, the Congress President, that we get allowed only one question because of shortage of time. So one question to Oliver from Spain on this excellent talk on protocols. Okay, Oliver, since there are no questions
I
from
think
the
we
audience,
have one question.
We have.
Yeah.
Okay, perfect.
Hi, Vikas, and thanks for your presence with us. Do we need a public relations staff to do this job?
As I have shown in my presentation, this is a very important multidisciplinary approach of the process. I mean, total hip and total knee actually is a process where the patient is the center, and you need a lot of people working around. So I think it's so important to manage all this stuff around the patient as important as the surgery. So actually we are all focused in the surgery, but the main improve in our patient actually with the standard total hip and total knee is around this surgery, not in the surgery.
Brilliant. Thanks, Oliver. Thank you very much for the question as well. We'll move on to the next talk. Thanks, Oliver. If you could kindly play the next talk, that would be great. And that's on the anterior approach. The debate continues. It's Professor Suresh Shiva from Malaysia, who's also the host for the next SICOT Congress in KL. Suresh, are you going to do it live or have you sent your talk in?
I believe I've sent the talk in. Have you guys got it?
If you could kindly play Professor Suresh's talk, that'll be great.
So I'm actually in the middle of a MOA meeting in Malaysia, so I couldn't do it live, but I believe my secretary has sent it in. Have you guys got it?
We have the video, I think.
Yes, that would be great if you could kindly play the video. Thank you. Thanks, Suresh.
Dear colleagues, dear friends, it's a pleasure to have the opportunity to present at this.
It will be the anterior approach by Professor Suresh Shiva from Malaysia.
In fact, we didn't receive the video, Dr. Kanduja.
Okay, so let's move on to the next talk and we can come back to this. Let's play Professor Sebastian's talk.
Okay.
So the next one, please. Sebastian.
Dear colleagues, dear friends, it's a pleasure to have the opportunity to present at this 37th Congress of the Tunisian Orthopedic Society our experience with short-term and hip replacements on behalf of the SICOT, Sébastien Lustig. I work in Lyon, France, at the Lyon North University Hospital.
Okay, so that's good.
So why, in my practice, a short-term makes sense? Honestly, it's very related to the shift, I experienced towards direct anterior approach, and I will show you why using a shortened stem is actually really easy and safe when you use this kind of approach. So this is a very nice example of a lady I operated on the right hip a couple of years ago with a typical stem I'm using, straight, fully covered with a hydroxyapatite and a collar, standard stem, and a dual mobility cup. More recently, you can see the kind of surgery we're doing now with a shortened stem, similar design, still a dual mobility, and a direct anti-approach. I will show you how this is actually making a lot of sense. To be very honest, we had no real issue with the standard stem. No real stress shielding at follow-up. Very few perioperative fracture was being proven to be very safe, even in elderly patients, and no thigh pain. Still, there were some ways for improvement. There is probably some way to facilitate the mini-invasive approach, some way to use shortened stem to preserve the bone stock in the field of tissue sparing surgery, and also this will allow to anticipate revision. When you look at the femoral stem explants, like this example, it's very clear that the distal part there is no osteointegration, even if it's fully covered with hydroxyapatite. You can see that the most significant osteointegration is at the proximal part, and the medial part there is still some amount of osteointegration, but definitely less than with the proximal part. So this is showing that the stress transmission between the self-locking stem and the bone is actually mostly located in the proximal zone, and this might be accentuated with the collar. So the question of the use of the distal part was actually making sense. So why short stem? Two fundamental principles for me. This is more physiological regarding the transfer of the stresses to the femur, and this is going to allow to preserve as much as possible the bone stock and the soft tissues in the field of the tissue sparing surgery. The expected objectives were decrease stress shielding, decrease perioperative fracture, avoid thigh pains, optimize the revision, and facilitate mini-invasive surgery. When you think about modification of design of stem, finite element analysis are quite useful. This is a model that's been developed by Group Lipin, considering the bone tissue, but also the stem-bone interaction due to the space between the stem and the cortical bone when you prepare using the rasp for the femur implantation. So this model is very accurate. We analyze three parameters: collar influence, stem length influence, because the shortened stem is combining both, and stem anchorage in the bone to see where it was located. Number one, the collar influence. This is very clear. The collar is creating a linearization of the stress. When you look at these two examples of the same design of stem, one with a collar, one with no collar, you can see that the stress is more homogeneously located at the proximal part of the stem, thanks to the collar. The consequences, and we showed this a few years ago with this cadaveric study, is this collar is increasing the stability in thinking, but also the stability in rotation, because considering the design of the stem with the angulation, of the cut, using a collar is creating a lot of rotational stability, which is very interesting, especially for, in case of osteoporotic bone. It's not only about the thinking control, it's also about the rotation. Regarding shortening of the stem, because we know that, how a standard stem is behaving. So considering shortening a stem by around 30% of the length, which is, beneficial regarding the ease of use, but is it going to jeopardize, the potential fixation or stress repartition? That's the key. The thing also, when we just consider using the familiar design but shortening the stem, is that it's going to be easy to use and no real learning curve. So this is the results with a stem with a small size. The size 9 is a small size, and you can see how between standard and shortened stem there is no difference in the stress transmission to the bone. And you can see that the distal part of the stem, which was not really useful because there was no stress here and no bone ingrowth, you can, remove it pretty safely. You have always to test also the large, stem. You went from 9, went to 16. You can see that this is even more beneficial. There is identical overall distribution, but now there is a lower stress level in the short stem compared to the standard stem. So when you go to the big size, going with a short stem makes even more sense. This is the way I switch my practice from a minimal invasive posterior approach to direct anterior approach. When I did this, I was using a standard stem from 2013 to 2017. What we could see, and we published it, is that we were increasing the varus positioning of the stem. Because you don't see very well the proximal part of the femur, you don't really get an easy access to the shaft, and the risk is to end up with a varus position of the stem that was very significant. When you look at this video, you understand why. Even if you use this kind of rasp to prepare the canal, you can see that it's really hard to know if you're in line with the shaft or if you're in varus. Potential complications, we all know that, is creating a damage for the great trochanter or creating a crack of the calcar because of this varus impaction of the stem. Of course, using some specific broad chandler, it's making this easier, it's enhancing the technique. We published that as well. We know that the double offset broad chandler are making it easier to be in the right direction. But this is an example. You can see the standard stem direct anterior approach, and using a standard broad chandler, it's really hard to be in the direction of the shaft. There is a risk, as I showed, of crack of the calcar or weakening of the great trochanter. If you consider the same standard stem, standard broad with a double offset broad chandler, you can see that it's easier to be in line with the femoral shaft and the femoral canal. But still, you have to have a pretty significant approach to get a good exposure of the proximal part of the femur. Now, if you switch to short stem, you can see that with any kind of broad chandler, it's super easy to be, aligned with the femoral shaft, with the canal, and to avoid the varus position. So if you combine this with a double offset broad chandler, just like this, and a short stem, you can see how it's extremely simple, and it's going to make this surgery, which might be challenging, actually very easy when you think about how you prepare the femur. So knowing this, you can move to some more challenging indication, like this patient when we perform a bilateral single stage direct anterior approach, and using this kind of stem, this overall surgery is not taking you more than 1 hour to do the both side, combined. So this is really helpful and simplifying surgery. And this is now something of course published. So regarding this short stem or mini stem, my experience is it's not essential if you want to do direct anterior approach. You don't have to switch to short stem, but they can be used safety. There is no risk induced by the shortened stem with a collar. It's easy to use, learning curve is short, and it does facilitate the femoral stem in case of minimally invasive approach or difficult anatomy such as varus, obesity, or muscular patients. Again, thanks for the invitation, and thank you very much for your attention.
Thank you very much, Sebastian, for an excellent talk. Unfortunately, Sebastian is traveling on the plane at the moment, so he can't take any questions. So we'll move on to the next talk, and that's Professor Stan from Ukraine. Could you kindly play Professor Bondarenko's video, please? Thank you. Thanks, Yusuf.
So we have Dr. Bondarenko.
Yes, that's correct.
We will play that video. In the meantime, we'll check again for the other videos.
Please, thank you.
Okay, Dr. Kadamcha. Okay, launch, please.
Good afternoon, dear colleagues. My name is Stanislav Bondarenko. I'm associate professor at the Orthopedic Institute of Spine and Joint Pathology in Kharkiv, Ukraine. First of all, I would like to thank the organizing committee, personally Professor Vikas for this great opportunity to take part in a high-level educational and scientific event. And today I would like to talk about spinopelvic biomechanics and implications on total hip replacement. I have no conflict of interest connected with this presentation. Spinopelvic motion is normally coordinated to allow balance of the mass of the trunk and hip motion with standing and sitting. In order to understand and define the spine-hip relations, it is important to understand the significance of spinopelvic parameters such as sacral slope, pelvic tilt, pelvic incidence, lumbar lordosis, and the C7 plumb line. Recent literature has reported that postural changes from standing and sitting, which can tremendously affect the stability of total hip arthroplasty. The normal spinopelvic motions occurs when a healthy flexible lumbar pelvic complex interacts with healthy flexible hips. Normal standing posture consists of slight anterior pelvic tilt with a mean sacral slope of 40 degrees and adequate physiologic lumbar lordosis to achieve sagittal balance. Normally, from standing to sitting adaptation process are performed, the sacrum moves posteriorly, the lumbar lordosis decrease, and the acetabular anteversion increase. The posterior tilt of the pelvis reduces the sacral slope to the same amount. Translation of the trunk over the pelvis is a key factor for maintaining the global sagittal balance during this translation from standing to sitting. Sagittal spinopelvis translation is an important variable showing the overall patient balance in different functional positions, which could affect the rate of hip instability. Various guidelines have been proposed for the orientation of the acetabular component in total hip arthroplasty. The most commonly cited guidelines date back to 1978, when arthroplasty surgeons still focused on placing components in the ideal leveling safe zone as determined by inclinations of 40 degrees plus minus 10 degrees and anteversion of 15 degrees plus minus 10 degrees in the static interoperative supine or lateral position. However, various authors have challenged the relevance of these zones and highlighted the lack of consensus between various guidelines. In a series of more than 9,000 total hip arthroplasty, Mediabel and co-authors showed that more than half of dislocation occurred with acetabular components which were placed with the safe zone. Stability of hip implant is likely multifactorial. The ideal cup position for some patients may lie outside the level safe zone. However, dislocation, age loading, and impingement more commonly occur during activities where the position of the pelvis and thus the acetabular component could be significantly different to that seen with static non-functional imaging. To achieve satisfactory results of a total hip arthroplasty, a good understanding of spinopelvic motions, acetabular location, and risk factors of impingement are needed. So far, many important investigations have been performed in this field. One of the most important was to find a relationship between pelvic tilt and acetabular. The growth in anteversion of the acetabular cup for each degree posterior pelvic tilt across approximately 0.7 degrees, which clearly shows the impact of pelvic tilt on the position of the cup. Another equally important parameter is the cup inclination, which increased about 0.3 degrees with 1 degree of increase in pelvic tilt. Abnormal spinopelvic motions from spine pathology is associated with inferior outcomes after total hip arthroplasty, including inferior patient-reported outcomes, increased rates of instability, and higher revision rates. To find these high-risk patients preoperatively, it is important to conduct the appropriate workup and formulate a surgical plan. A stiff lordotic lumbar spine requires greater hip flexion to achieve a sitting posture, and conversely, stiff hip joints demand more lumbar flexion to achieving sitting. The increased hip motion contributes to femoral acetabular impingement and total hip instability. This is particularly evident when aging results in degenerative loss of lordosis and moving the spine and then full body mass forward. In an attempt to maintain the global spinal balance, to maintain the head over the pelvis, compensatory changes occur in standing positions such as posterior pelvic tilt, knee flexion to shift the trunk pelvic center posteriorly. Patients with a stiff lumbar spine have a decreased ability to arthropelvic tilt, limiting the ability of the pelvis to accommodate increased hip flexion when seated. Prosthetic impingement and dislocation can occur if the acetabular component is placed with insufficient anteversion and inclination to accommodate the altered spinopelvic motion. Spinopelvic impingement can occur if there is insufficient offset. Standing and sitting lateral spinopelvic radiographs are able to identify and quantify abnormal spinopelvic motions. Depending on the type of spinopelvic deformity, some patients may require increased anteversion, increased offset, and large diameter heads for dual mobility articulations to prevent dislocations. The recent developed hip spine classification system allows surgeons to make appropriate evaluations preoperatively, and it guides the use of dual mobility components in patients with spinopelvic pathology in order to reduce the risk of dislocation in these high-risk patients. To conclude, I would like to say that spinopelvic alignment plays an important role in understanding hip joint biomechanics and the impact of residual changes in the spine on hip mobility. Abnormal spinopelvic mobility is a risk factor for total hip arthroplasty. Patients with combined spine and hip pathology at high risk should be identified and screened more carefully, especially in patients with suspected limited spinopelvic mobility. Spinopelvic measurements should be done in both sitting and standing position. This knowledge is essential for hip surgery as it is a way to avoid post-operative complications such as prosthetic dislocations, range of movement limitations, or prolonged pain after surgery. The crucial element of performing the surgery with the results satisfactorily for the patient is preoperative planning. Thank you very much for your attention.
Again, thank you very much, Stan, for the excellent talk. We don't have him here live, so it was a recorded talk. One last talk from Professor Siva. Suresh, do you have Suresh's talk, Yusuf? Checking. Could you kindly play Professor Suresh's talk? Checking again. Yusuf, could you kindly play Professor Suresh's talk?
Should I share my slide?
Suresh, if you can do it live, that'll be perfect.
Okay, I'll just share the slide. Okay, sorry that I don't know, my secretary might have sent it or it got lost, but thank you so much for inviting. I'm just going to give a really quick talk on direct anterior approach.
Suresh, your camera is off, Suresh, and you're not sharing slides at the moment.
Okay, can you see me now?
Perfect, got it. And if you could kindly share your screen as well.
Yeah,
that looks like a fairly empty screen.
Okay, wait, let me stop share. Give me a second.
Yeah, we got it.
You can, 1 second. Sorry, guys.
While Suresh is loading his talk up, the next SICOT meeting is in Malaysia, as you can see behind. We're delighted to host you there in September.
Can everyone see my screen?
That's great, Suresh, yeah.
It says the direct anterior approach, the debate continues?
Yep.
Okay, so this is just a quick talk on the direct anterior approach, and I just wanted to know how many people have done direct anterior approach and how common it is. But certainly the journey began for me about 5 years ago when I was introduced to the direct anterior approach by a senior colleague, and certainly started doing this. Why the direct anterior approach? Actually, we have been very happy with the posterior approach and the lateral approach, but why do we want to start a direct anterior approach? So this actually many people wouldn't know, was first described by Karl Huttner in Germany in 1881. And this is basically a modification of the Smith-Peterson approach. And as you all know, this specialized table was developed by Dr. Joel Matter, who is currently in Vail, and he developed a table with OSI called the HANA table. And the principles and basic techniques and approach are the same with or without a specialized table. It's basically the Smith-Peterson approach, and they do a slightly smaller incision. And the scientific basis of this direct anterior approach is that you have less soft tissue damage, faster and easier recovery, and lower dislocation risk. Initially, I was quite skeptical, but when I saw some of my more senior colleagues performing this with success, I decided to give it a go. So there are many papers which I can quote comparing a minimally invasive direct anterior approach versus posterior total hip arthroplasty based on inflammation, muscle damage markers. And there have been significant differences in levels of CRP, C-reactive protein, and other inflammatory markers in the direct anterior and posterior approach. The creatine kinase differences are less in the DAA approach compared to the posterior MIS total hip arthroplasty, and a number of prospective randomized studies have shown significantly improved outcome measures at 6 weeks, 6 months, and 1 year compared to direct lateral total hip arthroplasty. The reason I was getting into it was because the lower dislocation with the table, lower dislocation rate overall compared to posterior. And with the HANA table, it is easier to measure leg length intraoperatively using X-ray control. And therefore, you can actually document that your leg length discrepancy is very, zero or small. And as you know, a lot of patients post-operative complain about leg length discrepancy. And it's one of the biggest causes of dissatisfaction in total hip arthroplasty, leg length discrepancy, especially if the leg is slightly longer. So I found that with the HANA table and with intraoperative measurement of leg length discrepancy, we can actually document that the leg length is in fact equal, and therefore the patient can be reassured that their leg length is equal post-operatively. So the disadvantage of this direct anterior approach I found from personal experience is that you need a second assistant. So normally with a total hip, we can do it with one assistant, but with the direct anterior, you need a second assistant standing on the other side of the table to retract. And I've also found that the exposure of the femur is somewhat difficult. You need X-ray, and there is a risk of fracture, which is very real, as it has happened to me before. So in my series of 76 hips, I had no dislocations, no loose stems, one fracture of the femur, no infection, and the average length of stay was 2 days. So these are very small series, and I want to say that the learning curve is certainly very steep, and I would certainly encourage everyone who is doing a direct anterior hip to go learn from a mentor who can teach, and make sure that your first few cases are done with someone experienced, at least the first 25 cases, before you go out and do it on its own. Using the table has certainly helped, but I have done a number of cases without a specialized table, and it can still be done. And I feel that the patients do recover faster, they have less pain, but there is one thing I haven't mentioned, the risk of numbness along the anterior femoral nerve, and that's very real. So thank you for your time today, and I'm happy to answer any questions.
Thank you very much, Suresh. That was excellent. So we've done a fair bit of work on this, and And the real world difference between a mini posterior and an anterior or any approach that you're using seems to be fairly little. And every patient that walks out of theater following an anterior approach has got a numb lateral thigh or a numb anterior thigh. So if just being devil's advocate, if you are a good posterior surgeon, why should you be changing to anterior?
That's an excellent question, because I'm questioning that myself. I think if in your hands, mini posterior works well, and now we have the spare approach. A lot of people are doing the spare approach. I don't think there's any need at all to do anterior hip. But unfortunately or fortunately, I'm working in private practice, and there's so much hype. We have patients walking in asking for a direct anterior approach, and they don't want to do anything else because the marketing companies, especially the ones selling the beds, are doing all these marketing, and the patients are requesting an anterior approach.
So we've got our Congress Chairman, Professor Sufyan, who wants to ask you a question. They're not even giving him a mic there in his own Congress. That's amazing.
Thanks, because I think the debate is very long between anterior and posterior approach, but I think in the educational program, the posterior approach should remain, because there are some challenging cases that could be treated only by lateral or mainly posterior approach, which is much more extensile. Definitely there is a fashion of anterior which is giving better results, but I think the posterior approach remain one of the solution that in any educational program should exist, the posterior approach of the hip, to solve all the complex problems.
I completely agree. Completely agree.
Perfect. Thank you very much. Thank you, Vikas, for this wonderful symposium. Thanks for CCOT to be with us at the SOTCOT, and see you on Sunday for the ISACOS symposium. See you, Vikas. Thank you very much.
Thank you very much for the invitation, and thanks to all the speakers in the symposium as well. Thank you very much, Suresh, and thanks to SOTCOT for inviting us. Thank you.
Thank you, guys.
Bye-bye.
Thank you.
Thank you. Bye-bye.
We will go for the next session. Dr. Johnny and Khalil Amri, the moderator of the next session of oral communications. For anyone who wants to have a coffee break, you can grab your coffee and come back. Tous ceux qui veulent prendre un café, ils peuvent prendre leur café et revenir dans la salle sans problème, juste pour gagner du temps sur le retard qui a été accusé.